welcome to this new webinar of SELNET Consortium. In this occasion, focusing on biomarkers. It's a very interesting field within the sarcoma family tumors. So we have a very nice speakers, very expertise in this afternoon, and we will focus on this specific topic of biomarkers. And first of all, Seth Pollack will start with immunotherapy and biomarkers with immunotherapy efficacy in the sarcoma context. So my co-chair is Celso Mello, and he's the representative of Brussels in SELNET Consortium. So maybe Celso can introduce our speakers and say you the welcome words for this webinar. Thank you, Celso.
Hello, everyone. Can you hear me?
Yes.
Okay. Good afternoon in Europe. Good morning here in Brazil and America. I'd like to thank everyone for joining us today for our second webinar. We're planning to do more webinars on a monthly basis or every 2 months, and this is our second webinar, SELNET webinar. And today we're going to focus on sarcoma biomarkers, and we'll have the pleasure to have 3 distinguished speakers today with us. Dr. Seth Pollack. Dr. Seth Pollack recently joined as director of the sarcoma program of the Lurie Cancer Center at Northwestern University in Chicago. Dr. Pollack will talk about predictive biomarkers in soft tissue sarcomas. What are the perspectives for immunotherapy? And after that, we're going to have our second speaker, that is Dr. Paulo. Dr. Paulo is a very recognized pathologist on sarcoma. Dr. Paulo is from University of Padua, Italy. And our third speaker is Dr. Paul Huang. Dr. Paul Huang is a very well researcher on sarcoma field. Dr. Paul Huang is working on the sarcoma laboratory in London at the Institute of Cancer Research in London. After the speech, you're going to have 10 minutes for discussions and questions and answer also. And I'm gonna ask everyone to mute the mic during the speeches, and you can send the questions also through the chat here on the Zoom. So, Dr. Pollack, for us it's a pleasure to have you here with us today, and please feel free.
Yeah, it's great. The pleasure's mine. I'm really happy to be here. Let me share my screen. And all right, can you see the slides? Yep, looks good. Okay. So yeah, I'm going to be talking about biomarkers in soft tissue sarcoma. You know, the title of the talk that I'm supposed to give is Predictive Biomarkers for Soft Tissue Sarcoma in Immunotherapy. But of course, you know, we're way behind in immunotherapy for sarcoma, and we don't really have well-established predictive biomarkers for soft tissue sarcoma in immunotherapy. A lot of the questions that we're being asked are sort of the basic questions that some of the other cancers have already answered. You know, can soft tissue sarcomas respond to checkpoint inhibitors? Well, we know some of them can, but that's even still being sorted out. Is it a hot tumor? Well, probably some of them are. And what is the best biomarker to know whether these tumors are hot or cold, or whether they're going to respond? So, you know, really, I think, as with everything in sarcoma, it comes down to what sarcoma subtype are we talking about? And there's so many different sarcoma subtypes that I think it's really important to talk about immunotherapy in a subtype specific way. So, and of course, we know that there are certain sarcoma subtypes that seem to respond to single agent checkpoint inhibitor. Of course, undifferentiated pleomorphic sarcoma seems to have a lot of durable responses. This is from the classic SARC study where they treated 10 undifferentiated pleomorphic sarcomas, and 4 of them responded. There were some dedifferentiated liposarcomas that responded. Of course, in follow-up studies, it's not clear how many of these are going to respond. Leiomyosarcoma did not respond as well, and either did synovial sarcoma. So this is something that we have to be very careful of when we're talking about sarcoma and responses to checkpoint inhibitors. And this has been seen in other studies. Of course, there's a lot of checkpoint inhibitor trials out there, and some of the people on this call have done some fantastic work looking at different combinations. This is from our study with doxorubicin and pembrolizumab, and we saw good responses in undifferentiated pleomorphic sarcoma and dedifferentiated liposarcoma and some other sarcoma subtypes with that combination of doxorubicin and pembro. So really the key questions that I'll be kind of talking about are, basically the immunotherapy biomarkers that we know generally for all solid tumors. Are they applicable to soft tissue sarcoma? Microsatellite instability, mutational load, PD-L1, T-cell infiltration, other markers of antigen presentation, other immune infiltrates, and can these things be changed? I think we're just at the start of seeing how all of these different factors play into soft tissue sarcoma. And then the other thing that I'm really not going to be going into today is, could we make, there's lots of people out there that are working on making composite scores that use tons of data to try and figure out whether tumors are going to respond to immunotherapy, checkpoint inhibitor treatments or not. We're working on some of this for certain specific sarcoma subtypes. But, of course, in this study, this was a great study where they used gene expression data, and they classified tumors based on composite scores as to whether they're really like a more macrophage type, or they classified them by the Th1 to Th2 ratio in terms of their CD4 cells that were in the tumor. And a variety of other factors in order to kind of classify the immunophenotype. And they came up with basically 6 phenotypes, and this seemed to stratify patients prognostically. But those things are still a work in progress, and they're not really ready for prime time in that there's nothing like that people are using in the clinic right now that could help them make a decision as to whether to put a patient on a checkpoint inhibitor or not, or any immunotherapy for that matter. Really, the best biomarker in all of cancer for immunotherapy is microsatellite instability. And you can see some of these classic studies that show if you have microsatellite instability, your tumor is likely to respond to checkpoint inhibitor, no matter what your tumor type, as you can see on the right. And on the left, if you have colon cancer and you have mismatch repair deficiency, you are likely to respond to a checkpoint inhibitor, regardless of your tumor type. Well, in colon cancer, but also this stretches over any tumor type pretty much. But mismatch repair deficiency is very rare in sarcoma. It's not non-existent. So, we are generally doing NGS on pretty much all of our metastatic patients, and the common NGS panels look for mismatch repair deficiency and microsatellite instability, and if we see it, we know that's a good patient for a checkpoint inhibitor. But you could see that in this study, they looked at over 304, or they looked at 304 sarcomas, and only about 2% of them had this. So it's really going to be hard to figure out who to target this for. Of course, if you're doing NGS, you may stumble upon it. So it's good to keep your eye out. Really, most of the patients with microsatellite instability or mismatch repair deficiency had either pleomorphic rhabdomyosarcoma or unclassified sarcomas. So that's something to keep in mind with your patients. This is just sort of a cute thing. I wanted to kind of mention that we know that alveolar soft part sarcoma is one of the immunotherapy subtypes that is most responsive to checkpoint inhibitors, and we don't know why. It's a translocation associated sarcoma, so it has a low mutation, it doesn't have very many natural mutations that are driving the tumor, but we don't know what its mutational load is generally. There's differing opinions, and I don't think there's good published data that really characterizes the mutational burden in alveolar soft part sarcoma. But one thing that somebody did report once was that there are some alveolar soft part sarcomas that have mismatch repair deficiency. And I think that's a really interesting finding. There was a discussion about this at CTOS. Why does alveolar soft part sarcoma have such great responses to checkpoint inhibitors? Some people think it's there may be viral antigens that get turned on through the epigenetic reprogramming that happens with these tumors, but it's a big mystery and it's something I'm interested in. Really curious if anybody has any insights. We can talk about that during the discussion. But mutational burden generally is a key factor in checkpoint inhibition. And this is, of course, the classic slide where we see the more mutated tumors tend to be more responsive to checkpoint inhibitors. And this seems to be true in sarcoma as well. This is a classic study where they looked at the mutational burden of the more common sarcoma subtypes. So they didn't look at alveolar soft part sarcoma, but they found more mutations in these tumor types where we think sarcoma subtypes where we think that they should be responsive to checkpoint inhibitors, like myxofibrosarcoma, like undifferentiated pleomorphic sarcoma. So PD-L1, of course, is an important biomarker for checkpoint inhibitors. We know that in other tumor types, a lot of tumors can respond without expression of PD-L1. They can respond to PD-1 inhibitors. But we know that sarcomas or that tumors that express PD-L1 tend to be more responsive, but we don't know if that's true in sarcoma. We don't know if that's true in the undifferentiated pleomorphic sarcomas. We don't know if that's true in dedifferentiated liposarcoma. We don't know where PD-L1 fits in as a biomarker. In fact, I think it's I don't even think we know how much PD-L1 a lot of the different sarcoma subtypes express, and the literature hasn't been generally good at framing this question in this way, which sarcoma subtypes have a lot of PD-L1. We looked at this in our 2017 cancer paper, and we found that the undifferentiated pleomorphic sarcomas had significantly more PD-L1 expression and more PD-1 containing infiltrates than other sarcoma subtypes. Interestingly, we found that the second best, based on kind of the stuff that we looked at, that you would expect would be leiomyosarcoma. Of course, leiomyosarcoma doesn't have a lot of responses to checkpoint inhibitors, but there may be other factors in the tumor immune microenvironment that are contributing to that, and we'll talk about that a little bit later on. One thing that I'm really interested in, and I think is very promising as an emerging biomarker, is T-cell receptor sequencing. And we have a lot of interesting data that I'm hoping to get out soon. T-cell receptors, of course, if you think back to your basic immunology, they undergo a rearrangement. That's how you get such a diversity of different T-cell receptors. They have this VDGA rearrangement where the genes all get mixed up. So the T cells actually have different genes for the T cell receptor than one another, and then the rest of your body. And you can do sequencing just on the T cell receptor, and that allows you to give a very accurate quantification of the number of T cells in a sample, and also allows you to judge the diversity of the T cells in a variety of different ways. So, for example, when we looked at T cell fraction, that's just a very precise way to quantify how many T cells are in a sample. We found that undifferentiated pleomorphic sarcomas had more T cells than other tumors, particularly more than synovial sarcoma or myxoid round cell liposarcoma, which of course are genetically simple translocation driven tumors. And those tumors also had a higher clonality. So clonality is a metric for how specific the T cell response is. So if you have a random assortment of T cells, they undergo their rearrangements, and there's however many 10 to the 12 different T cell receptors in your body. If it's a random assortment of them in a sample, that would have a very low clonality. Whereas if there's a relatively small number of T cells making up most of the T cells in a sample, that's a sample that would have a high clonality. And undifferentiated pleomorphic sarcoma has a high clonality, suggesting the T cells there, they're not random. They're doing something. Probably a T cell got there, it recognized its target, it started to divide, and now you have a higher proportion of that T cell in the sample. that's what it means to have a high clonality. And it does seem like these undifferentiated pleomorphic sarcomas have higher clonality. Again, leiomyosarcoma, you'd say, just looking at this data, that it would be in second place. And of course, we know those tumors are not great at responding to checkpoint inhibitors. This is kind of how this sort of thing can be incorporated into trials. This is from the immune design first vaccine trial. There's more data coming out about this sort of thing. We found that patients who had a higher clonality in their peripheral blood tended to do better in terms of progression-free survival and overall survival following the vaccination. So that was an interesting finding on that vaccine trial. Of course, this wasn't a randomized trial, so this may be just something that's true of synovial sarcoma patients generally, or it may have to do with the vaccine specifically. We don't know. So T cells don't recognize the tumor abnormal proteins in a tumor directly. They have to recognize the abnormal proteins as presented in an MHC complex, right? So this is, again, basic immunology. So if you have, for example, a viral infection, the viral proteins get broken up in the endoplasmic reticulum, and there's part of there's what's called the immunosome, which is all the different broken up, sliced up proteins that get shipped out to the MHC complex, and then they get presented on the cell surface by the MHC complex. And that's the only place the T cell can see them. And that's why, for example, on these T cell therapy trials with the gene-modified TCR, the gene-modified TCR can't just see the NY-ESO-1 or MAGE-4 directly. It needs to be in the MHC complex, which is HLA specific, right? MHC is kind of the same thing as HLA, and that's why these patients need to have A0201. But we know that synovial sarcoma and myxoid round cell liposarcoma have very low MHC expression. That's what I'll show you that in a second. This is an example of a synovial sarcoma that has NY-ESO-1, but it has very low class 1 expression. And this is another biomarker in other tumors. This is something, MHC expression is another thing that people have linked to checkpoint inhibitor response in other tumor types. And this is from our study where you can see, again, the undifferentiated pleomorphic sarcomas have more of the different HLA expressions than synovial sarcoma or myxoid round cell liposarcoma. And these other sarcoma subtypes seem to do better. What about other immune infiltrates like B cells? We know there's been great data showing that B cells seem to predict survival for sarcomas, and that seems to be independent of histology, and they seem to predict for immunotherapy outcomes, and that may have to do with the tertiary lymphoid structures that are in these tumors. And that's something that is really important that we've got our eye on, and we need to incorporate better into our immunotherapy trials. And this study that was really focused on rhabdomyosarcoma basically seemed to support the prior Nature study that I was showing, that B cells have a critical role, and that tertiary lymphoid structures seem to play a crucial role in predicting outcomes of these patients, particularly in the context of immunotherapy. People ask, I put this in there just because people have been asking me, will you show that there's not a lot of T cells in synovial sarcoma, but I saw a report that there were, and there are T cells around synovial sarcomas, they're just not in the tumor. So for whatever reason, synovial sarcoma seems to prevent T cells from getting into the tumor very well, and they accumulate at the invasive margin of the tumor, and there's a lot of PD-1 expression at the invasive margin, as well as these CD8 T cells, and it would be really great if we could figure out ways to get these T cells into the tumor. Macrophages, of course, are the last immunoinfiltrate that I want to talk about. As this Tolman study showed very well, there's a lot of different things going on in the tumor immune microenvironment, and macrophages are probably a very important part, particularly for the leiomyosarcomas, which have a lot of inhibitory macrophages. But it's not just leiomyosarcoma. People think about leiomyosarcoma, but you can see angiosarcoma and undifferentiated pleomorphic sarcoma, liposarcoma. These all have a lot of macrophages, and they're not all doing the same thing because, of course, angiosarcoma and undifferentiated pleomorphic sarcoma, these are sarcoma subtypes that we think of as responding well to checkpoint inhibitors. And of course, macrophages can have different phenotypes. And this shows that they have similar 163 expression. 163 tends to be thought of as a marker of inhibitory or so-called M2 macrophages. But M2 and M1 is not, it's not like having a CD4 cell or a CD8 cell, right? M2 and M1 is a collection of different features of macrophage, and macrophages can have both M1 and M2 characteristics. So M1 macrophages are thought of as being immune facilitators. They can they eat bacteria and tumor cells, and they can present antigen on their cell surface. And that's why they express HLA-DRs, because they're important antigen presenting cells that can stimulate the CD4 response. Whereas the M2 macrophages are thought of as the, quote, wound healing macrophages. They release TGF-beta and IL-10, and they can be very suppressive to the T cell response. But it's not as simple as M1 versus M2. There are macrophages that can produce both inhibitory cytokines while simultaneously presenting antigen on their cell surface. So it's a more complicated picture than that. But of course, these immune infiltrates have been linked to prognosis of leiomyosarcoma patients, and patients with inhibitory markers on their macrophages have poorer survival than patients without inhibitory macrophages in their tumor. So just with my last couple slides, can the immunotherapy be changed or overcome? We did this trial. This was at a time where we were still kind of, for our very refractory sarcoma patients, synovial sarcoma and myxoid round cell liposarcoma patients, a lot of them were going on checkpoint inhibitors because we didn't know what else to do when we had access to it, but it would take a while to get access. So we started this trial where we would treat patients with a short course of interferon gamma, which is FDA approved for other indications. And we did, and these were all patients who had easily accessible tumors for biopsy. And we did a clinical trial where we did pre-treatment biopsy and post-treatment biopsy after interferon gamma. And we found that we were able to really increase the amount of T cells in these tumors. You can see all but one of these patients had a increase in the T cell infiltration of their tumors. And when we looked for NY-ESO-1 responses, of course, we know that synovial sarcomas and myxoid round cell liposarcomas, in a majority of cases, express NY-ESO-1. And in some of these patients, we were able to show NY-ESO-1 specific T cells developing naturally. But we also saw increased MHC expression, so they had better antigen presentation. But they also got a lot more PD-L1, especially on the myeloid cells that were infiltrating these tumors. And we actually did run a PD-L1 plus interferon gamma trial where we're finishing the analysis now, but we didn't see responses on that trial. So the getting a checkpoint inhibitor response in synovial sarcoma and myxoid round cell liposarcoma, it's more complicated than just using interferon gamma to increase the T cells in there and increase the MHC. There's other things that we're going to need to do, and hopefully as part of this analysis, we can figure out what that is. We also tried to combine, I don't know what these marks are, but we also tried to combine interferon gamma with T cell therapy. And we did that in 2 patients, but we had a fatal myocarditis that developed in one of these patients. One of these patients had a great response. This patient was quite sick. This is the one with the CT scan, who had a great response. And that patient was quite sick when he went on the trial. He was able to go back to work. His pain improved. He was able to come off opioids. The other patient, though, had a fatal myocarditis. And we do know that there is some urine data showing that interferon gamma can increase macrophage infiltration of murine myocardial tissue. And we think that the macrophage infiltration caused by the interferon gamma combined with cyclophosphamide, which does have some minor myocardiac toxicity. People don't realize it, but in the original trials of cyclophosphamide, cardiac toxicity was the dose-limiting toxicity, and it's still something that the transplanters are mindful of in patients getting a high lifetime dose of cyclophosphamide, much more than we typically use in our solid tumor patients. So this is back to kind of the original questions we were talking about before. Does sarcoma have microsatellite instability? It's rare. What about mutational load, PD-L1 expression, T-cell infiltration, markers for antigen presentation? Yeah, there are sarcomas that have these things, and there are certain subtypes where this is particularly important. Are there other immune infiltrates to be aware of? Well, B cells and macrophages, of course. And can the immune microenvironment be changed? Well, we're working on it, but there's still a long way to go. And histology is probably the #1 consideration for soft tissue sarcoma right now. So thank you, and I'm happy to answer questions.
Thank you so much, Dr. Pollack. We're going to open it for some questions right now. Questions for the audience. Javier, Nadia.
Hi, Celso. This is Felipe speaking.
Hi, Felipe.
I have a question for Dr. Pollack. There are some types of soft tissue sarcomas, for example, alveolar soft part sarcoma, that is fusion-driven sarcoma, has a low tumor mutational burden, and is very, very few immune cell infiltration in the stroma, but is one of the sarcomas that you can find some reports describing response to checkpoint inhibitors, and also in AC Camargo have a case that is responding for 2 or 3 years to checkpoint inhibitors, pembrolizumab, for example. And how to explain, what do you think, what's the reason for this type of sarcoma that has very, very cold that respond to immunotherapy?
Yeah. So I had a couple slides about that. So that's a big question. Alveolar soft part sarcoma does respond in quite a few cases. Now, I talked about the tumor mutation burden in that tumor a bit. I don't think we really know what the tumor mutational burden is across the board. I've definitely seen patients where the tumor mutational burden is low. But I don't know. There may be patients where it's not low because there's this report that some of these have mismatch repair deficiency. That's an older report, but that would sort of suggest that there's a fraction of the tumors that have a higher mutational burden that isn't just the translocation driving the whole tumor. The other thing I was mentioning is, and I don't think we know this, but this is kind of one thing that's been floated out there as a possible explanation, is there are people have described latent viral antigens that are part of our genome, and some have suggested, without evidence, to be sure, without evidence, but as sort of kind of theorizing, that maybe the epigenetic reprogramming that the alveolar soft part sarcoma mutation translocation pushes forward brings forward some of these latent viral antigens, and I think that may be particularly immunogenic to some T cells. So those are a couple explanations. I don't know the answer, but yeah, I think that is a major question for the field.
Okay, thank you for the answer.
I have one question here from the audience. Dr. Pollack, is there a place for checkpoint inhibition and radiation-induced sarcoma?
Yeah, I think there is. I mean, there's definitely been some nice case reports, case series describing sort of individuals with radiation-induced sarcomas that have responded to checkpoint inhibitors. I think these tend to be highly mutated. they, I mean, a lot of the times they are the types of sarcoma that we think about. Undifferentiated pleomorphic sarcoma and angiosarcoma, of course, are very common subtypes of radiation-induced sarcomas. So I personally am using, you know, in my refractory radiation-induced sarcoma patients, I'm trying checkpoint inhibitors. I think it's a good thing to do.
Javier?
Yeah, Dr. Pollack, talking about the immunogenic death, do you consider is there any relevant biomarker? I mean, at the baseline of this treatment, or maybe as a variation of the biomarker expression, calreticulin, for instance. Have you tested in this way some relevant biomarker in the combination of chemotherapy plus anti-PD-1, for instance?
Yeah, no, well, we looked at it in, we didn't have kind of pre and post treatment tissue tumor in our doxorubicin study. We tried to look in the blood, but we didn't see that in the blood. But that doesn't mean that it's not going on. Yeah, we really need trials that have that are some of these combination trials, and you know, we've got some going on. I know that you guys have a lot going on. We really need these trials to incorporate biopsies that look at these things from before and after. And yeah, I think calreticulin is a good one. Yeah.
Thank you.
Thank you very much for the excellent presentation, Dr. Pollack. I think we could move to our next speaker. Our next block will be coordinated by Dr. Nadia Hindi and also Dr. Rodrigo Munoz from Hospital Sírio-Libanês that will coordinate the second block of the lecture. Nadia and Rodrigo.
Good afternoon. It's our pleasure being here again. And we have the pleasure this afternoon to have Professor Paulo de Tos, who is going to share with us his talk about prognostic biomarkers in sarcoma. So Paulo, I think it's your time. Thank you very much.
Hello, maestro. Thank you, Nadia, for inviting us, and hello to everybody. I'm trying to share my screen now, and one of the things is following, wonderful set talk. My talk is at the risk of being a little bit depressive because, when you talk about biomarkers in sarcomas in general, prognostic, predictive, as also said alluded to, is not so easy to find anything really, really effective. But anyway, what is a biomarker? I try to go through that FDA Food and Drug Administration definition, which is not much help because, of course, they tend to focus so much on the physiology, the toxicology, pharmacology. EMA is a little bit better. So in a way, but as you can see, the main interest that EMA has, of course, is in predictive response. Not only, of course, to immunotherapy, but also to many, many different things. In terms of predictive biomarker, we have some, and of course, the best example is always GST, where we do have some credible biomarker of response to the different lines of treatment of targeted therapy. Well, but in principle, what do we have? We may have positive prognostic biomarker, let's say, well, Ki67 is something we never use, thank God, in sarcomas. But in a way, if it is allowed, let's say in breast cancer, you can single out those people who have a better outcome. And of course, they can be negative, just like, for example, KRAS mutation in colon cancer, and you pick up, the one who, for example, wouldn't respond to EGFR treatment. Well, in sarcomas, it's not that easy. So we try to start from the very beginning. And what do we have at hand in terms of parameters that we can use to stratify patients in order regarding the outcome? Well, as you know, in WHO, we try hard, for example, to tell people, all right, be careful, because in the real life, there is not only benign and malignant thing, but also we have things that in a way we call intermediate. And of course, it's not to be confused with the intermediate grade sarcomas. You grade sarcomas once you already decide it is a sarcoma. But just to acknowledge a situation in which, for example, you have diseases which are locally aggressive but never metastasize. And this is a typical example that you may have is desmoid fibromatosis. And then you have some kind of exotic things like plexiform fibrous city tumor that we know very rarely metastasize. And of course, you don't really define how much a rare is rare, but let's say that's a 5%, that's a 3%. As I mentioned, one credible biomarker of outcome has been historically grading. And our French friends actually managed to develop the best example that we use. As most of the pathologists know, it is just kind of a score in which you take into account mitotic count, tumor necrosis, and histologic grade. And of course, histologic grade has to do with some resemblance to the tumor to the normal tissue. But here comes the first obstacle, because many sarcomas actually do not resemble any normal tissue. So how can you do that? Well, of course, our French friends, and the list has been updated recently within an international collaborative initiative that want to standardize reporting in cancer in general, but also in sarcomas, and this is going to be published very, very soon in some journal. But anyway, of course, you can tell that PNAT, for example, Ewing, let's say, is all the tables, so some of the names are a little bit crazy, have a tumor differentiation score which is prefixed. So that makes life a little bit easier. And this is what happens basically if you use this type of scheme for some of the sarcomas. You may have some kind of a spread between the grade 1, the grade 2, and the grade 3, knowing that in the grade 2, actually, some of them will do well and some of them will do bad. And honestly, we are not so good in telling which one are the bad boys or the good boys. But I will come back soon on this concept. And in the ICCR initiative, which I just mentioned to you, we try to elaborate a little bit and say, okay, we have a bunch of sarcomas in which in reality, we can't really use the grade. So there are tumors which are definitionally high grade, like Ewing, all the rhabdos, all the angios, and so on. Even if there has been an attempt, for example, to grade the angiosarcoma, but now we know it's just a dream. Whatever it looks like, angiosarcoma tend to behave very, very aggressively. Then we have a situation in which the lesions are definitionally low grade, like let's say well-differentiated liposarcoma, the FSP. Infantile fibrosarcoma, infantile fibrosarcoma can look pretty bad, but in reality, we know that the chance of cure for those little boys is like 95%. Also in the era of the NTRK obsession. And then we have tumors that we can't grade at all, because if you try to grade according to the principle of necrosis of mitotic activity, let's say alveolar soft power sarcoma has been already mentioned, that's one of the good candidates for immunotherapy. But actually, it looks very low grade. Clear cell sarcoma can be low grade. Epithelial sarcoma can be deceptively bland and innocent looking, but is an animal which kills most of the patients. You know, admittedly, maybe it takes 10, 15 years, 20 years, but most of those patients actually get diagnosed with epithelial sarcoma when you're very young. So still a very, very dramatic and deadly disease. Synovial sarcoma is the one thing that should be actually graded, because some data from the French sarcoma group would indicate that G3 is far worse than G2, but there is no consensus. And so, low-grade fibromyalgia sarcoma, almost impossible to grade on the terms of the French system, because it looks very bland. It is low grade in the label, in the definition, but it actually substantially aggressive on the clinical grounds with a lot of recurrence and metastatic spread. And then we have lesion in which grading or tumor-specific risk assessment may be prognostically useful. So we don't have a grading system, basically. And I will touch base on selective fibrous tumor quite soon, just to show you how can we use these schemes, which looks a little bit like half staging, half grading. Let's think of GIST, for example, but they seem to work much better than simply try to stick on morphologic parameters or biomarker, if you prefer. And then we have a situation in which really can't grade at all, like epithelial margin of the glioma. There is some attempt, but not validated. Only getting extraskeletal myxoid chondrosarcoma. We have the feeling like we have low grade or high grade stuff, maybe also related to specific gene fusions, like TAF15, for example. But again, it's so difficult to come with or to offer something which is really solid and reproducible. So one of the things which is kind of ironic is that, you know, we all live the era in medical oncology of the agnosticism and the pathology agnostic type of approach that think of NTRK and the powerful push to use things like foundation one in sarcomas. Well, actually, histotype. So by definition, the morphology in many cases is one of the best predictors of outcome. So when we tell to our clinical colleagues the specific diagnosis, they will know exactly what they have to expect in alveolus of pars sarcoma or epithelial sarcoma and so on. And again, morphology is not only relevant when dealing with specific histotypes, but just take MPNST. MPNST, as you know, is a quite complex diseases. You know, patients have a broad age of occurrence. There is this very fascinating association with the NF1, with the von Reich diseases. And we know that in that setting, in that genetic setting, there is a risk which is between 2% and 10% to develop malignancy through the lifespan. And this is just one example of the daily looks. You can see the sciatic nerve and this bag of worms that most likely was represented by plexiform neurofibroma that evolves into a full-blown malignancy. And one of the fascinating things of MPNST, that is one of the rare models in which you have tumor progression for, in an NF1 context in particular, in a full-blown evolution from benign to pretty much high-grade malignant neoplasm. Of course, sometimes going through lower grade type of neoplasm. And this is the classical morphology that we all learn to know. Well, one of the things is that MPNST have a tendency to exhibit heterologous differentiation. So for the non-pathologists, this is chondrosarcoma in MPNST. This is osteosarcoma in MPNST. This is angiosarcoma in MPNST. This is rhabdomyosarcoma in MPNST, which is also being termed malignant triton tumor. And look at this. Two things seem to impact over clinical outcome. One is being or not being NF1 associated. So with NF1 associated MPNST basically doing worse than sporadic ones. And then, all right, look at just the overall survivals of 5 years, 50% in sporadic cases, 25 if you are an NF1 patients, and then 15% if you have post-radiation cases, post-radiotherapy sarcoma. And you know that the three main things that occur post-radiation is angiosarcoma, osteosarcoma, and MPNST. If you do have rhabdomyoblastic differentiation, then occurrence drops to 10%. And if you have angiosarcoma, 0%. So that's why, in a way, morphology, when dealing, for example, MPNST, and well, is the only way that to tell something meaningful in terms of what to expect in terms of outcome. And then another point I would like to raise with you is, okay, the new sarcomas, this chick rearranged sarcoma, the big core rearranged sarcoma, not because I want to teach based on on this specific genetic aberration as a specific biomarker of outcome of specific predictor, even if we know basically that chick rearranged sarcomas and because rearranged sarcoma exhibit a peculiar clinical behavior. So in a way, again, the specific label here will tell you that BICO does far better than Ewing's and chick, and that chick is particularly aggressive. And you know, as medical oncologists, that chick docs doesn't work so well with Ewing's chemo, which of course opens a whole discussion on what would be the best treatment for this patient. But again, it is a specific example in which a specific diagnosis somewhat translates into some spatial clinical behavior, and of course raise the room for discussion among clinicians and among pathologists as well, what to do with this. Another amazing example of how morphology can be so tricky is leiomyosarcoma, which now, it's not so frequent actually disease, but it's a complex disease. And here the biomarker is not the histology itself, but is the anatomic site. Prognosis in leiomyosarcoma is an anatomic site-dependent factor, but to make things even more complicated is also a gender-dependent factor. As a matter of fact, a retroperitoneal smooth muscle tumor that would make malignant in males with the same criteria would be benign in females. And this is kind of amazing how, more than clinical, that pathological data can be so dramatically impacting over prognosis. And let's see. For example, you have an intra-abdominal leiomyosarcoma, overall survival at 5 years is 20–30%. If it's, gets up to the soft tissue of the limbs, then you raise the chance of survival to 60%. If the same identical lesion, horrible maybe on the microscope, is in the dermis, you never get metastasis. If it is in the subcutis, maybe 5%, but basically all those patients, exactly the same morphology, are simply cured by excision, local excision. So, same level, prognosis depending of a kind of a clinical biomarker that is site. And as I mentioned to you, if you have a smooth muscle tumor in the retroperitoneum, which is a good place for being a leiomyosarcoma, all right. In female, you're allowed to have up to 10 mitosis. So mitotic count in this case become the biomarker, the prognostic biomarker. But exactly the same lesion with the same mitotic count would kill a male patient. And this, of course, is something you have to take into account. And this comes from all the work that Marco Miettinen did at NIH on retroperitoneal leiomyosarcoma, trying to see the differences between males and females patients. And then situation that drive you crazy. How can you predict the outcome of solitary fibrous tumor, the hemangioparasitoma of the old times? It's almost impossible because, of course, if the lesion looks horrible under the microscope with a lot of mitosis, with necrosis and diffuse atypia, well, this is going to behave like a high-grade sarcoma, of course. But then we know that 20% of SFTs will metastasize independently from the morphology. That's why, substantially, Liz D'Amico tried to change the approach. Since then, we only have one criteria, having more than 4 mitosis per 10 HPF, or let's say per 2 square millimeters, if you want to be more modern. But now they decided, I think they were right, to try to factor in several other factors. Some are clinical, like the age. Apparently, being older than 55 is not a good thing if you get a solid fibrous tumor. Tumor size, which seems to be reasonable. Mitotic count. Presence of necrosis that in the context of a soft tissue sarcoma seem to have some relevance. And then you can score it and try to have a low, intermediate, or high grade, which is more or less what we did with GIST, didn't we? And this, of course, you can have the heat map or the contour map that put together with Heikki Joensuu. You can have nomograms. You can simply have to play with anatomic site, with mitotic count, with size of the lesions, and presence or absence of intra-abdominal rupture of the lesion. And then you can have a decent prognostication in this type of tumors. And this is, of course, the classical morphology of GIST that you all know. Certainly, we never managed to factor in molecular genetics, even if we proved now, a few years ago, that the genetics of GIST is not only predictive of the treatment, but is also, in a way, prognostic. And we know, for example, that KIT exon 11 does perfectly well with imatinib and most of the drugs, but also define a more aggressive disease. And if you wish, increase the rationale, enhance the rationale for treating these patients even at the neoadjuvant stage. And the fact that histology is relevant, well, is now regarded as relevant also when you try to develop or to use survival nomograms, in which not only you have, the age, the size, the grading, you also have the specific histology that is going to impact over the calculation of the outcome. And of course, as you know, our friends in Milan had the brilliant idea to develop an app, which is called Sarcolator, which is probably sounds nice in English. I will promise you in Italian sounds really, really terrible. But anyway, it is a nice way in order to factor in different things, which are in part clinical, but in part are pathological. It will be nice in the future to try to factor in also molecular determinants. Why don't we do it now? Well, because genetics actually, and moving on to genetics, didn't prove so much helpful. We had some hope with a so-called SYNSARC, which is a CGH array profile generated by the French group. Now they move also to nanostring as an alternative, maybe easier technique. Well, the problem is that, which I foresee, but this type of approach seems to work according to the people who developed that. Would be feasible for using in breast cancer, with lymphoma, with melanoma, which is, to me sounds a little bit strange. We also try within EuroSarc to use to validate this approach in our series for the neoadjuvant study, but we know that, as far I know, that the data, which probably has been submitted to ASCO as well, were not positive, so it was a negative study. So in reality is that the first external validation of SYNSARC didn't prove to add much to what we know already. And if you want to use the fusion genes, the gene fusion as a possible prognostic determinant, well, they tried to do it, but it was a total disaster, basically. And I will just show you, this is a couple of papers, so the New England Clinical Cancer Research, where the friends from the Memorial Sloan Kettering tried to correlate the different transcript of the SYT-SSX fusion type in synovial sarcoma. And as you can see, they provided some evidence that was true, which was very strange from the beginning, which is a discussion I had several times with Mark Ladani, because fusion genes are very, very early initiating and inventing these T sarcomas. And so I don't expect them to be prognostic. And in fact, when they started, they left from a retrospective analysis to a prospective, to other bigger database. Actually, that's what happens. No prognostic significance at all. Actually, grading synovial sarcoma was actually the most relevant prognostic biomarker. So G2 versus G3, basically. And the same happened with Ewing's. And when, for years and years, people told us, based on retrospective studies, that the type 1 EWS fusion had a prognostic benefit. So we start fantasizing for years, why don't we use this to stratify our patients? And then came the data from the Ewing 99 trial, where they had prospective study, and prospective evaluation denied at all any value of the gene fusion variants on prognosis. We have a little bit more hope with desmoid fibromatosis that, as you know, is a beautiful neoplasm, never metastasizing, but underlined by a very, very interesting Wnt pathway aberration, which of course involves mutation in most of the cases of beta-catenin, but in Gardner syndrome, you have mutation APC. Whatever is a mutation, you have accumulation of beta-catenin in the nuclei, which of course can be used diagnostically. And Alex Lazar did some efforts and trying to see that probably the 45F mutation, which significantly correlate with increased desmoid tumor recurrences. There is still debate on this, but anyway, we are now collecting prospectively. Guys in Milan are also doing the same, and you see some signal. You see some signal that may, in a way, you may think of using mutation analysis in order to try to see which are the progressive one versus the non-progressive one, which is particularly relevant because, as you know, we currently think that wageful waiting is the best way to treat at the beginning, at onset, desmoids, because many of them actually would regress spontaneously or would stay stable spontaneously, it is also interesting. That was the surgeons to tell the best treatment is not to treat them surgically at all. Couple of words, a little bit more, even more repressive on Ewing sarcoma and osteosarcoma. Well, of course, I left on purpose out any discussion on the many so-called prognostic molecular biomarker. Correct, the p53 mutation is bad prognostic biomarker. The truth is that when you go into multivariate analysis, most of those parameters actually lose most of their significance. That we show one personal example of that. And of course, Ewing's and osteosarcoma are so relevant, and you will see here. For example, we found that P16 expression can be a prognostic or predictive marker in a localized osteosarcoma. The problem here that if you do P16, this is stay valid only if you only look at the P16, but if you do multivariate analysis, many other things like necrosis, for example, just overwhelm P16 expression. So the truth that we are not left with so much when dealing with osteosarcoma and Ewing's. Actually, what we can do, what traditionally is still being done, it seems to work pretty well, prognostically, but also predictively, of course, is the evaluation of tumor cell necrosis. And of course, you can have different ways to do, like use the pure percentage, the Hoover system. Of course, as Italian, we are very fond of the Bologna system, but we just, this Bologna system is going to basically grade. If you have macroscopic areas of tumor, viable tumor, if you only have isolated nodules that you will see being confined within 110x field, or no viable cells, which of course is a very good scenario. And this is what you see basically, a lot of tumor, just isolated tumor islands, and then no tumors at all. Which also, if you compare with osteosarcoma, is interesting because a grade 2 Ewing is not good at all. In osteosarcoma, if you have this type of amount of tumor, is very good. It would be regarded as a very good response. And of course, the type of tumor makes a lot of a difference. And in terms of evaluating response, we are very good in bone, but as you know, we are really struggling in soft tissue. And actually, we recently showed that probably when you're going to establish the response, the best correlation with the Bologna system, but any system actually correlates pretty well. But we are just talking about necrosis. I mean, in the era of NGS and molecular genetics, we still don't have so much to play with. So the conclusions is that prognostic tools in sarcomas are rather limited, mostly based on morphologic evaluation. If you exclude GIST, there is no much contribution of molecular genetics, a few other things. And definitely we need to struggle, we need to use all our consortium, all our sarcoma community to improve and to identify meaningful prognostic biomarker. And that's the end of my talk. Thank you for your attention.
Thank you so much for the very comprehensive and very clear overview of how to incorporate potential biomarkers in our daily practice. We do have some minutes for some questions from the audience. I still
Oh,
haven't received
I
none.
see. I see. I see.
So I do have one question, Professor. We do understand the different biology and the molecular characterization of different subtypes of Leiomyosarcoma family tumors, but how do we translate that into treatment decisions regarding the optimal perioperative systemic therapy? Do we have any clues on how to better manage patients with B-core or sick ducts fusions instead of standard Leiomyosarcoma?
Well, you know, this is, I think it's very difficult. We have discussed the issue so many times. The problem is that, you know, if you are a fan of frequentistic approaches, you will say, okay, we don't have the data. We don't have the data because basically we have like 200 or 300 cases published until now. If you put together B-core and chick sarcoma, and chick sarcoma. If you know, consider that in this rare disease, if we don't accept a different approach, I'm thinking about the Bayesian way to go through, we will never have the data. So we start from a situation in which we know that the response in chicken B-core is not good. So they don't really respond like Ewings. We also know that B-core does far better than chick. So I think this is a question that should be really addressed in a specific, with a consortium like we have, would be feasible, I believe, in trying to see whether on this specific patient we may even simplify the protocol treatment. So there is a good reason to treat a chick ducts with 6 drugs or 8 drugs, whether for 12 months, for 12 cycles. I mean, knowing that in the end we are not getting so much success with that. So I understand it is difficult, but I think this is an answer we need to find in order to offer better chances. My feeling is that the toxicity we are giving to patients with chick duct sarcomas is really maybe too high for what they have and for what they can achieve from that. I don't know whether you agree or not.
Yep. Yeah, we do face the same challenges here. I guess, Nadia.
Sorry, I have a question, Paulo, for you. You have perfectly shown that we mainly rely on morphology to make prognostic evaluations. What do you think is the reason of the failure of genetic or molecular prognostic profiles like SYNSARC? Do you think it's a question of all histologies put together? Do you think it could be worth to make a specific molecular profiles for each histologic subtype, for example, or to integrate all the things, not only gene expression, but also metabolomics, immune profiles? I don't know. What do you think?
Well, I don't know. You know, if you look into SYNSARC, in the end, what they look at mostly into proliferations system. I mean, which is probably in sarcomas is not the only. Well, I mean, SYNSARC seemed to work in the series of the French sarcoma group. Is just my the impression is not the impression, is the fact that when we try to use in our big series of the French, Spanish, and Italian sarcoma group, it didn't work at all, which is not a good sign, I would say. It's not a good sign. But probably we need to look into those data and try maybe to elaborate, because, you know, also the bioinformatic analysis sometimes is kind of challenging. If you go back to the issue of profiling, what I can tell you, you know, I just tried to mention Foundation 1, which was the oncopanel they extensively used at Dana-Farber, doing almost 2,000 cases. And if you remember, Andy Wagner simply say, okay, we stop using it because the yield was ridiculously low. And in addition, the 2 papers that Genevieve just published on this type of approach, you know, with the SPECTA EOTC, basically they're both negative studies. So of course they conclude, okay, we need to go more in depth in the future. But the reality that we start in a situation in which this approach doesn't seem to work so much with sarcomas. And which of course is a little bit, you know, disappointing. I understand, because I'm not trying to disvalue molecular genetics, because it's something I strongly believe in, But it's just considering that at the moment, the result we get is so I mean, disappointing, and that's it. So that's why in the end, we rely on morphology, which is good, but on the other side is also underlines the fact that we are not really improving on the other side, which is maybe we need to change, you know, the approaches and to consider and to factor in, as you mentioned, immunogenicity in sarcomas, which, you know, when we do gene profiling, basically we just look at, you know, proliferation marker, you know, tumor suppressor genes, proto-oncogenes. But now we know that the immunogenicity, that the epigenomic landscape is equally relevant as it is the genomic landscape. And so the issue is how we can integrate all these different approaches and data in order to come with something which is meaningful. Then I can see a couple of easy questions here. What is the prognostic value of the diff liposarcoma grading? Well, we do believe, because we developed this data, which is important. So the feeling is that G3 versus G2, according to the French system, is meaningful in terms of outcome. And it is also a rhabdomyoblastic differentiation, which is to define an extremely aggressive type of the diff lipo. Do you suggest NGS platform to any subgroups of sarcomas? Well, academically speaking is what we do. And in particular, when we are dealing with the round cell sarcomas and differentiated round cell sarcoma is what I do, because, you know, in a WHO, we said, which is not obligational, is not mandatory to use fusion genes identification in order to make the call of chick sarcoma and because sarcoma. I think which is totally craziness. So I understand the motivations, but, you know, if you want to call something chick sarcoma, you have to prove there is the chick rearrangement. Otherwise, you can call Paulo de Tos sarcoma, which is the same, you know. At least we have Paulo de Tos. But in this case, I think is very, very important. In particular, also getting back to the first questions. I mean, if we want to really even think of different therapeutic approaches, we need to have the diagnosis. We need to have to prove what is the genetics behind. And you know, a WHO will say, okay, but, you know, this has to be good for everybody, including those countries in which you can afford NGS. I'm perfectly aware. But then when we come to these countries in which you are the chance to look to get into those platforms, I think we should do. Mm-hmm. So not for any sarcomas, but in particular when you have specific subsets in which the genetics is part of the label.
Mm-hmm. Perfect. Thank you.
Thank you, Paulo, so much. I believe. Go ahead, Nadia, please.
Oh, go you speaking.
I think that
I believe we need to move forward. Yeah, we need to move forward. So I'd like to thank you very much and hand over to the next moderators, which are Tiago Santos and Felipe Almeida, both from AC Camargo Cancer Center here in São Paulo, Brazil. Thank you so much once again.
Thank you. Thank you all.
Hello, everyone. Can you hear me clearly?
Yeah.
Okay, so let's start the last talk of this meeting, which has been an excellent meeting, actually, with almost 100 people connected all over the world. And I have the honor to introduce the next speaker that will talk about perspectives in biomarkers development for sarcomas, modeling and validation. And it's Dr. Paul Huang from the Institute of Cancer Research, London in the United Kingdom. So Dr. Huang, have you a nice talk. And thank you very much for accepting for this, participate in this meeting.
Thanks so much. Thanks also to the organizers for organizing this very useful series and for inviting me speak. I was given the remit to give my perspectives on biomarker development. So this is going to be quite a data light talk. But also just to point out that my talk's probably going to even be more depressing than Paulo's talk. So we'll see what people think at the end of it. So, but I'm going to focus on challenges and opportunities in biomarker developments. So I think it's fair to say, you know, biomarkers is really an exercise in reducing heterogeneity. There are different ways to go about doing it, but fundamentally that's what we're trying to do. So if you have a mixed population, patient population, heterogeneous population, you're trying to find something that is able to then separate out the groups which, you know, either will respond to a drug or more aggressive versus less aggressive disease, risk of relapse, and the list goes on. But I think it's important to point out that a bad tumor biomarker test is really as bad as a bad drug. And this is a mantra really put forward by Dan Hayes from Michigan. And he's been pushing, you know, this idea that, you know, we really need to put a lot of effort in developing and validating our biomarkers properly. So the idea is he's put forward this idea of a vicious cycle where really a lot of things that are being put out there have very low level of evidence. And this, what this leads to is obviously, you know, no take up in terms of recommendations for clinical use, clinical utility is poorly valued, and this has a knock-on effect in terms of funding, both federal funding, but also commercial interest. Now that really hasn't stopped the community. I think everybody of us is probably in the room is probably guilty of this. I am definitely guilty of this, of putting in our grant proposals. We will identify biomarkers for cancer X. And just to put this into perspective, I went into the NIH, this is the US NIH grant database, and looked at how many grants were awarded with the words cancer biomarker. And this is basically what the spend is. So you can see that it peaks at $2.8 billion a year. Now, I'm sure all of you will agree with me that this huge amount of money has not really translated into clinical biomarkers. So where is the problem? And also what has caused this huge explosion that you see in this really steep slope here? And I think one of the challenges is that we can now very easily profile tumors. It's cheap, it's easy, and one could argue, you know, is molecular profiling the solution or the problem? This is just one of these very generic figures where, you know, you can take your tissue and you can do a lot of things to it now: genomics, transcriptomics, proteomics, metabolomics, and the list goes on. The idea is you put it into this magical funnel, you integrate it with your clinical and imaging data sets, use various informatic approaches, clustering, more sophisticated statistical modeling, machine learning, and deep learning. And then at the other end, you get this magical output of an omic biomarker. It is able to tell you if a patient is going to respond to a drug or not, or is prognostic for something. And of course, we all know the reality is conceptually it's a very nice idea. And you know what this has generated is effectively a paper mill. So there's a lot of papers that have been published, you know, with people analyzing a lot of tissue and then generating a lot of putative biomarkers. But in reality, very, very, very few groups have reduced this down to practice. I would say sarcoma, there's nothing yet that's in clinical practice. In breast, we have a couple of examples, I think colorectal as well. So really, one question is, you know, there's an investment there. This is what we're finding. The other question is, why is it so difficult? And the reason is that it is actually incredibly difficult, if you do it properly, to get a molecular test into clinical practice. So before you even have a test that goes into testing for clinical utility, by that I mean your prospective trials, you need to go through analytical and clinical validation. And this is where many so-called biomarkers fail. So this is, I'm just showing this quite nice diagram here. Sorry, it's a bit busy, but on the left is the discovery phase, on the right is a validation phase. So the discovery phase, I think many of us are familiar with. We take a cohort, we do all sorts of profiling on it, and then we confirm using an independent set that, you know, what we see in our training set is able to what we usually call validate. But in reality, there needs to be a second validation step, which is the analytical validation, to make sure that what you're measuring, what you think you're measuring is actually what you're measuring, and what sort of tissue, FFP versus frozen, and so on and so forth. And then evaluate that using a blinded sample set for clinical validation. And it's only then when you have a defined, validated, and lockdown test, and by lockdown, it means you lock down for intended use, the assay is locked down, the computational algorithm is locked down, and the interpretation criteria is also locked down, do you then go into clinical utility evaluation? And that is, when you start thinking about your prospective trials. And so it's difficult, and some of it is structure, some of it is practical challenges. For sarcoma, one of the practical challenges is trying to get so many validation data sets to actually show that your biomarker is real. And there are other structural challenges as well. Now, one may ask a philosophical question is, with the huge heterogeneity that we're seeing in sarcoma, is this even possible? Should we even bother? And I don't need to tell this audience, and I think Paulo has very nicely summarized it in his talk, the huge variation, tissue of origin, age, histological subtype, anatomical location. Is it really practical to think that we can resolve this down into biomarkers? So with that background in mind, I think what I'm going to talk about today is just these three things. I'll give an overview of what has been in the pipeline development for sarcoma biomarkers so far. I will not, in this case, I'm going to talk about more multi-gene type, multi-analyte type assays as opposed to, your single mutations or your fusions like NTRK. And I'm also not going to talk about the immune biomarkers because Seth covered that in his talk. I'll talk a couple of slides about our experience in kinase inhibitor biomarker development, and then end with some challenges and opportunities. And I think it's all very exciting to talk about, what's currently all the new technologies, single cell sequencing, all that kind of stuff. But I think we also need to recognize, I think pioneers in the field, those who actually started some of these initial analysis. So in the early days, 10, 11, 12 years ago now, groups like Matt Van der Rijns, Colin Cooper's started to use emerging technologies, then these gene expression arrays to look at sarcoma and ask, a question of if we were to just take different histological subtype, does the gene expression data tell us anything? What they were able to show in those days was that different subtypes had different gene expression profiles, and you can differentiate them based on gene expression. And then what Matt did was to go one step further, which is to look at specific subtypes. So in this case, leiomyosarcoma, and using unsupervised clustering, consensus clustering actually show that there is molecular heterogeneity within these subtypes. So if you look at leiomyosarcoma, there's 3 different molecular subtypes shown in these different colors here. And this has been validated in different cohorts now. So what we know is that LMS can be molecularly classified into 3 subgroups. And there are some, ideas about potential drivers, potential targets, and even some very weak signals on prognostic factors. But the reality is, it's fair to say that this is really nice for biology, but there's no clinical utility yet. I think what we need to do as a community moving forward is really think about at the forefront of it, how do we actually reduce this down to practice in terms of clinical utility. And I know that there are various groups trying to work together to define some sort of consensus of moving forward in terms of clinical utility. But notwithstanding that, it is a valid approach, and others have used it. For example, recently a group from Singapore showed using the IO360 panel from NanoString that you can functionally, using functional annotations, functionally separate angiosarcoma into 3 groups. And one of these groups is the group with the high tumor mutational burden that the angiosarcoma project identified as well. And then French colleagues identified in undifferentiated pleomorphic sarcoma using various omics modalities that there are 3 subgroups. But the point to say is that these are very small numbers. If you think about the diagram I showed earlier, they're really at the top left-hand side of the discovery phase, and there's a long way to go before, even though there's a weak signal for prognostication, there's a long way to go before putting this into clinical practice. The second type of molecular biomarker I'm going to talk about is this idea of NGS, next generation sequencing, in patients with no targetable mutations. So by this I mean that you don't get the I don't know, PI3 kinase mutation or a BRAF mutation. It's something along the lines of, patterns you see in the genomic data. And I think Seth talked about MSI as one example. Now, I think one idea that's quite interesting is this idea of BRCA-ness, and this originated really from the whole BRCA deficient story, where BRCA deficient breast cancer patients, for instance, have defects in homologous recombination repair, DNA repair, and this is a synthetic lethal interaction with PARP inhibition. So trying to broaden this out further, this concept of BRCA-ness, where in some cancer types of high-grade serous ovarian cancers, triple-negative breast cancers, there are alterations in genes involved in the HRR pathway, as well as various mutational signatures, and taken together, they can give a so-called BRCA-ness phenotype/genotype that may be indicative of response to PARP inhibition. And so some groups have actually shown using whole exome sequencing data that, for example, Priya Chudasama, as shown from Heidelberg, has shown that if you look at leiomyosarcomas, you can find genetic aberrations in some of these genes in quite an enriched subpopulation of these patients, and similarly in osteosarcomas as well. So potentially the BRCA signature may be indicative of response to PARP inhibitors. There are a couple of, I think 2 or 3 PARP inhibitor trials being conducted at the moment, and I think as part of their correlated studies is to go back retrospectively to look at the tissue to see if there's an interaction between any BRCA type phenotypes with a treatment response. So we'll see what happens with those studies. And then the final category, if you will, and Paulo has touched upon this, is these transcriptomic signatures based on biology of sarcomas that are in various stages of clinical development. All these I call subtype agnostic or pan-sarcoma type methodologies. So for example, SYNSAR has already been mentioned. As its name suggests, it's chromosome instability, pathways, for instance, and proliferation. The second one is a genomic grade index, which is actually adopted from breast cancer and shares many features actually with SYNSAR. So there's some overlap in terms of these 2 signatures. And finally, there are these hypoxic signatures. So this idea that tumors that have hypoxic, so lack of oxygen, have different outcomes than tumors which are more well oxygenated. And I think SYNSAR is probably the one that is the most furthest along in terms of its clinical development. It was first reported in 2010. It has gone through, credit to the authors, the whole analytical validation and clinical validation, in the sense that they have developed an assay that originated from gene expression arrays to RNA-seq, and then nanostring based on a single sample predictor, and have done the clinical validation in terms of looking at different retrospective data sets. So now, 10 years on, they're now going on to various testing the clinical utility in various prospective studies, and I've just picked up one. There's several ongoing. So for example, this one, if you're interested in the protocol, has been published, where they use a SYNSAR signature to distinguish in grade 2 the so-called high risk and low risk, and trying to see whether additional chemotherapy in a perioperative setting is going to make a difference. So there is this constant question that at all these consensus meetings, one's always asked this idea of level of evidence, and the challenge with all these biomarkers: are we ever in sarcoma going to get the level of evidence, just because of the rarity of the disease and the ability to recruit enough patients? And so I think the group, the French sarcoma group, should really be commended for designing and trying to recruit 600 patients. So we'll see what happens with this, but it is the one that is most close in terms of clinical utility. On our side, we've worked 6-7 years now developing biomarkers for some of these dirty kinase inhibitors, or multi-target kinase inhibitors they're currently being used in either treatment or trials in soft tissue sarcomas. And I think kinase inhibitor is probably a class of drugs for which we have the most experience in terms of companion diagnostics and biomarkers, whether it be KIT, PDGFR, GIST for imatinib, Philadelphia chromosome for CML, EGFR mutations and EGFR inhibitors for lung cancer, for instance, and the list goes on. But of course, many of the so-called multi-target kinase inhibitors that we use in sarcoma, either approved such as pazopanib or being used in trials such as regorafenib, sorafenib, sunitinib, axitinib, all don't have biomarkers. They were all approved based on an effect that was seen in a randomized study, but if you randomized trial, but if you look closely, the effect sizes are actually all very much smaller than what you would see, for example, with an EGFR inhibitor in the mutant EGFR lung cancer. So there is a window of opportunity here. Now, one might ask philosophically, why has it been challenging to identify biomarkers for these drugs? So these are my personal views. Happy to discuss them. I think the thing to say is that with all these genome sequencing efforts, I think it's fair to say we've probably identified the majority of cancers driven by single drivers, whether it's BRAF, ALK, EGFR, and TRAC. There might be a few more that arise, but for the most part, I think we've done most of it. The second thing to say is that cancers, as we all know, are driven by multiple complex processes, not just genetics, as many of these very selective target drugs go for, also epigenetics, not just the tumor cells, but also the microenvironment, the immune cells, the fibroblasts, the endothelial cells, all play a role. And finally, the polypharmacology. So these drugs hit many things. I think we are all in agreement that we don't know what is the target for pazopanib in soft tissue sarcoma, if it's even one target. It might very well be that the kinase inhibitors hit different targets in different cells. It might hit various kinases in tumor cells and a different set of kinases in immune cells and fibroblasts, and we have no idea. And so maybe it's a bit naive to think that a single mutation or a IHC expression of a protein is able to separate out and stratify patients, and maybe we need to think about new ways of biomarkers for this class of drugs. So what we developed is a single sample predictor algorithm that is conceptually very similar to SYNSAR, which we've called kinase inhibitor activity and response in sarcoma. And the idea here is to get a pre-treatment patient specimen, put it through an algorithm. I put nanostring here, but it's platform agnostic. Put it through a lockdown algorithm, and it basically splits out into two groups. Either you are in subgroup A, which you should consider therapy because you're likely to benefit, and I'll show you the data on the next slide, or an unfavorable gene expression profile where you should think about alternative therapies. And this is just the data when we applied a single sample predictor in again, mindful to say it's a retrospective cohort. We can very nicely separate subgroup A, as you can see here, with a median PFS of 13 months versus the other subgroups. For all of you who give these sort of drugs, administer these drugs to patients, you know in general the median PFS for these drugs is somewhere in the order of, 3 to 5 months, if not less than that. And we validated independent cohorts. I'm not showing you the data. We've also looked at pazopanib naive patients and shown is predictive, not prognostic, and done all the usual multivariate analysis. So this lockdown assay is now, hopefully, we're going to phase 2 trial together with Vinod Ravi and MD Anderson, which hopefully will recruit later this year. So outstanding questions of biomarker development. I think these are questions that I think many of us actually don't really think about when trying to develop these assays, and I think they are important to consider. So is biomarker performance impacted by, for example, intratumor heterogeneity? We all know if you look grossly at anatomy of these sarcomas, they are very, very heterogeneous. So this hasn't been looked at in any shape or form and systematically. What many people do, for example, in SYNSAR, you would basically take a cutoff. So if you have less than X% of tumor cell, you basically can't do the assay. And then there is an added step when you're doing your centroid correlation analysis. You fall between two centroids, or you can't classify the patient, you basically exclude that data set. And that's probably due to things like, at that data point, that's probably due to things like intratumor heterogeneity. So hopefully with techniques like single cell sequencing and deconvolution techniques, maybe we can start to address this in a more systematic way. There's an issue with treatment effects. Nobody's actually looked. A lot of these are biology-driven biomarkers. So you would imagine if you treat a patient with a drug, you're going to change the biology. So what's going to happen to the subtype call? unknown at the moment. Time point, we all know about tumor evolution, selection of various clones. Is primary tumor the same as metastatic tumors? So does that also influence the biology and therefore the subtype call of these biomarkers? And finally, the age-old question of subtype agnostic or pan-sarcoma versus subtype specific. All these biomarkers I talked about just now largely claim to be subtype agnostic, which, makes it easier, I guess, when you think about recruiting for trials. But I think our experience tells us when we look at some of the trials that have failed that, it's likely that if you go for a subtype specific approach, you're likely to get a cleaner signal. So again, things to consider. So just to wrap up my last 2 slides, I think fundamentally in terms of trying to overcome barriers, I think fundamentally all boils down to biology, and that might just be my bias as a scientist. I think we really have a very poor understanding of sarcoma biology and heterogeneity. Heterogeneity can come in many shapes or forms: intra-heterogeneity, inter-heterogeneity, tumor versus stroma, all those questions. Very, very incomplete knowledge of factors that drive patient relapse. The circulator is fantastic in terms of looking at risk of relapse and high risk, defining high risk patients, but the biology underpinning that, I think needs to be examined, investigated. And also drug resistance and response. It's quite shocking actually to say that we actually don't know very much about mechanisms of resistance and response for many of the drugs that are given to patients today. So if we can chip away at some of these, the idea is hopefully we can develop better biomarkers and smarter clinical trials. So just going back to the vicious cycle, I think we now really want to try and move towards virtuous cycle rather than vicious cycle. So the key here is high level of evidence. If we can really do good analytical validity and good clinical validity before going to clinical utility testing and trials, I think we have a chance of really breaking the cycle and then having a knock-on effect on all the other aspects of this. And in the context, in my personal view, in the context of sarcomas, I think this is probably the way that we are going, is that you have your first level of subtype, most obviously histological subtype breakdown, and then using subtype specific biomarkers to identify other prognostication or predictive capabilities. So with that, I want to thank you. If you're interested in these 2 topics, we published recently MPJ Precision Oncology, and this one probably coming out soon in Current Opinion Oncology as well. Thank you for your attention, and happy to take any questions.
Dr. Huang, first of all, thank you very much for this outstanding talk. It was really, really amazing to watch this history of development of biomarkers, and especially in sarcoma. We have some questions from the audience, but first I would like to make my personal question to you. You show the difficulty to find biomarker to existing drugs, but what if we think in the opposite way? So one of the first targeted therapy was imatinib, that was found looking for inhibited a gene fusion that was BCR-ABL1. So in the last years, we could see the development of other targeted therapies, also targeting gene fusions, such as that ones involving ALK and ROS1, and more recently, NTRK1, 2, and 3. So since we know most of the gene fusions that drive many sarcomas, such as EWSR1 and other many sarcomas that we already know, the fusions are very constant, and the other alterations are very few. Why it's so hard to try to find drugs that inhibited these gene fusions, since we know the downstream signaling pathway of these fusions and the gene expression that is driven by these fusions?
Yeah, so I think there are several levels to that question. So I'm going to try and address. I think the first is not all gene fusions are equal. So there are gene fusions, as you said, EWSR1. Those are difficult because they're transcription. It's historically been difficult to target transcription, and this is more to do with drug discovery and chemistry ability to find pockets in these sorts of drugs, these sorts of proteins, rather than anything to do with conceptually targeting a fusion. And you're right. So, if the disease is driven by a fusion, it's much easier to target a fusion than its downstream pathways. And of course, we know in Ewing's, Jeff Turetsky has this very, very nice drug that hopefully we'll start seeing very nice data coming out soon. So I think, and there are a lot of very, very nice drug discovery tools like PROTECs that are coming out, where you don't actually need to have a specific small molecule for a specific, you can use degraders to try and destroy transcription factors or undruggable targets. But there are those, as you pointed out, ALK or NTRK, which are actually targetable because they're effectively kinases, just different forms of kinases. And you're right. I think the thing to bear in mind is that many of these drugs were not necessarily designed to target those original targets, right? They tried, some of these were designed for something else and actually failed, and then were then repurposed. So there's a whole element of, should we be repurposing our drugs? I think there are a lot of these high throughput screens that are looking at that sort of thing and trying to develop general rules, like if you have a BRAF mutation, you're more likely to be susceptible to drug X, and you're more likely, if you have, you're more likely to develop this sort of resistance mechanism. So again, conceptually, it's doable. People have been trying to target downstream components for a very, very long time. I mean, not even fusions. I mean, things like, undruggable oncogenes, KRAS is the most dominant example. And I think that's more to do with drug discovery, I would say. We know the biology. We know if we genetically knock down the fusion, the cells senesce, they die. So it's more about, do we have the chemistry to be able to target those fusions?
Oh, thanks. Great answer. Thank you very much again. Tiago would like to make a question.
Actually, hi everyone. Celso has a question in the chat. Celso is asking how to improve the modeling and development of biomarkers since subtypes are rare and difficult to perform clinical validation. Animal models are useful, and I also question in terms of organoids. Are you betting in organoids?
Okay, so let's tackle the animal question first. So so I think the first thing to say is that a mouse is not a human. So yes, animal models are important, but it's important to recognize the limitations of animal models. A classic example is the ASPS mouse that was developed by Kevin Jones in Utah, where it developed ASPS, but it was in, I think, a different anatomical location or something to that effect. So there are limitations, but they are useful to a point. So I think that's a very good point, especially in terms of the rarity. But fundamentally, I think at the end of the day, we're going to have to look at human tumors. A mouse only lives for 2 years. And some of these, you have to accelerate the development of the tumors. The types of mutational burdens that you get are different. Because it takes time for tumors to accumulate those sorts of aberrations. So there are limitations, but yes, I think they are useful to a point. Organoids or spheroids or whatever we want to call them, operationally what an organoid is, but yes, it's, I think, a very useful approach. I think the sarcoma field is probably quite far behind versus many of the other cancer types, and it's not clear whether that's because the cancer types are easier to grow, or it's because it's a mesenchymal tumor, and therefore all the tools that we develop for carcinomas may not work for mesenchymal tumors. So I think if we can overcome that barrier, it will be a great screening tool, definitely for matching drugs to patients and that kind of stuff. In terms of biomarker development, I think it's hard to say. I mean, I don't really have a strong view one way or the other. For drug screening, I think, it's great to study biology. It's great. In terms of biomarker development, I still think at the end of the day, we have to go back to the patients and go back to actually evaluate whether it's tissue or blood or, whatever biospecimen, ideally in a prospective manner, but as we all know, that's difficult in sarcomas. So we have to work with what we can get.
Thank you. Celso, anyone?
Thanks so much, Dr. Huang and all the speakers. We have a great, fantastic afternoon today with these incredible lectures. And I would like to close the meeting and invite Dr. Javier and Nadia to make the final remarks and reminders for the next meeting. Thank you, all the attendees. Thank you, our colleagues from SELNET, and thank you for the speakers for the incredible lectures today. And have a good day. Nadia and Javier.
Yes, thank you very much, as Celso mentioned, to all the speakers, brilliant speakers. And thank you to all the attendees. The peak of attendance was 96%, which is very, very nice number. And also thanks SELNET hosted Brazilian today. Thank you, Celso and your colleagues. So be aware with the upcoming events of SELNET. Be aware about the initiation of multidisciplinary sarcoma committees, and also the pathology webinars, specific pathology webinars, and the next webinar also is scheduled. These presentations, these lectures will be uploaded in the upcoming week. So for your opportunity to see in more slow and degustating time. So thank you very much for all your effort. And maybe Nadia can add some detail for the next webinar, or the dates or schedule.
Yeah, so the next webinar, as this format, will be in June, the 24th of June. But at the end of this month, we will have our first MDT virtual meeting. It will be the 28th of April, and colleagues from Alexander Fleming will coordinate it. So we will hope that you can all attend also this meeting. We will circulate more details and then the link and everything through the mail. And also all the information is in the website of SELNET, so you can take it there. And now I would like to take a photo. So if you can
turn out the
please.
camera.
Let's go, guys. Don't be shy.
So, yeah, 1, 2, 3, smile. Again, I have to take more because we are in several screens. Smile. And the last one. Okay, perfect. So thank you very much. And see you soon.
Thank you. Bye-bye.
Thank you.
Thank you, everyone. See you soon.
Bye, everyone.
Yeah.